Welcome back to the deep dive. We have a stack of research on the desk today that, I'll be honest, most people would nervously shuffle to the bottom of the pile.
Yeah.
We are heading into territory that is universally experienced, but rarely discussed. Medically, it's critical geography. Socially, it's often considered taboo.
It is indeed. But avoiding this topic is a luxury that, medical professionals simply do not have. We are looking at the anus and the anal canal. We aren't just winning it with general knowledge today.
No.
We are doing a rigorous forensic analysis of Chapter 80 from the 28th edition of Baily and Love's Short Practice of Surgery.
The gold standard for surgical trainees. And I think we need to be very clear about our mission here right from the start. This isn't a dramatic reading of the textbook, is it?
Absolutely not. And this is really important. We are interpreting this chapter to make it easier to digest and remember. This is not a regurgitation. It is a companion guide. If you are a surgical trainee preparing for the MRCS or a medical student facing finals, you still need to open the physical book. You need to study the anatomical diagrams of the ischiorectal spaces and, memorize the fine print.
So what are we doing here?
What we are doing here is building the mental scaffolding.
Yeah.
We are interpreting Chapter 80 to give you the anchors, the why, and the how, so that when you do read the text, the information sticks. Think of this deep dive as your high-yield revision companion.
A roadmap before the journey. And speaking of roadmaps, we have a clear path today. We're starting with the geography, the anatomy that dictates everything. Then the detective work how to examine a patient without missing the obvious. And finally, the pathology, the big three of fissures, hemorrhoids, and itch, followed by the darker side of sepsis and incontinence.
It is a full itinerary.
It is. And looking at the notes, I was struck by a contradiction. The anus is basically just a valve at the end of a tube. It seems so simple.
It does seem simple.
Yet the engineering required to make it work is...
Yeah.
It's mind-boggling.
That is the hook.
Yeah.
You might joke about the location, but biomechanically, the anal canal is a masterpiece. I mean, think about the requirements. It has to differentiate between solid, liquid, and gas.
Right.
It has to hold back contents under massive abdominal pressure when you cough, sneeze, or lift weights, and yet it has to relax completely on command. It is a high-stakes, high-precision security system.
I like that, the security system. So let's map the perimeter. Where does the rectum end and the anal canal actually begin? Because lay people, they use those terms interchangeably.
And that is a fatal error in anatomy. They're distinct environments. The anal canal begins exactly where the rectum passes through the pelvic diaphragm, specifically at what we call the anorectal ring.
Okay.
And it ends at the anal verge, where the moist mucosa meets the dry skin of the buttocks. In adults, we are talking about a tube that is only, 3 to 4 centimeters long?
That's it.
Yeah. Longer in men, a little shorter in women.
Tiny but complex.
Yeah.
So walk us through the security system. Who is guarding the gate?
We have 2 main guards. And understanding their personalities is the key to understanding all anal surgery. Guard number 1 is the internal sphincter.
Okay. Let's build a profile for him. What's he like?
I call him the night watchman. This is a thickened continuation of the circular muscle of the rectum. He is involuntary, autonomic. He is always on duty, maintaining a resting tone that keeps the door shut while you sleepwalk or work. He accounts for about 80% of your resting continence.
80%.
And if you were to look at him during surgery, he is pearly white.
So he's the baseline tension. But he's not just a dumb clamp, right? He reacts.
Oh, he does. This is the fascinating part. When the rectum fills up with stool or gas, the walls stretch. This triggers something called the rectoanal inhibitory reflex. The night watchman momentarily relaxes.
Wait, he opens up?
He opens the door just a millimeter.
Why on earth would he do that if the goal is to keep things in?
To let the sensory nerves in the upper anal canal sample the cargo.
To take a peek at what's coming.
Exactly. Is it gas? Is it liquid? Is it solid? Once the sample is taken, if it's not time to go, he clamps back down. It is a biological sampling port.
That's sophisticated. But what happens if the night watchman realizes, this is liquid, and we are in a public meeting?
That is where guard number 2 wakes up, the external sphincter. I call this one the emergency brake.
The manual override.
Exactly. This is voluntary, striated muscle. It's red, bulky, and supplied by the somatic nervous system via the pudendal nerve. When the night watchman signals a threat, your conscious brain grabs the emergency brake and squeezes.
A conscious decision?
Yes. You can double the pressure in the canal instantly. But like any sprint muscle, it fatigues. You can only hold that brake for about a minute.
So the internal guy is endurance, the external guy is power.
Precisely. But there is a third structural component that Baily and Love emphasizes, the puborealis sling.
The sling. This isn't a ring muscle.
No. Visualize a garden hose with water running through it.
Yeah.
If you want to stop the flow without a valve, what do?
You kink it.
You kink the hose. The puborectalis muscle forms a U-shaped sling around the junction of the rectum and anus and pulls it forward towards the pubic bone. This creates the anorectal angle, literally a kink in the gut.
So the weight of the stool sits on the kink, not just on the door.
Correct. When you squat to defecate, that sling relaxes, the angle straightens out, the hose unkinks, and gravity takes over. It's brilliant biomechanics.
Before we leave anatomy, we have to talk about the line. The text mentions the dentate line repeatedly. Why is this specific border so famous in surgery?
The dentate line is the watershed. It's the border between two embryological worlds. Above the line is gut columnar epithelium. Below the line, it's skin squamous epithelium.
Okay.
But the reason it matters to a doctor is the wiring.
The sensation.
Yes. Above the dentate line, the nerve supply is visceral. You can cut it, burn it, or band it, and the patient feels only a dull pressure or stretch. They do not feel sharp pain.
But below the line.
But below the dentate line, that is somatic innervation. It is incredibly sensitive to pain, temperature, and touch.
So this is the pain line.
That's the anchor concept. Below the dentate is where the pain lives. If a patient comes in describing excruciating razor blade pain, the pathology is almost certainly below that line. If they describe vague discomfort or bleeding without pain, it's likely above.
That is a crucial diagnostic filter.
Yeah.
Double click on that for the listener. If you are about to perform a procedure, knowing where you are relative to that line determines if the patient walks out smiling or
screaming. It is the difference between a minor office procedure and a lawsuit.
Let's do a quick check-in here for the listeners. I want you to pause and think. If a patient presents with a lesion that is causing sharp cutting pain every time they sit down, is that lesion likely above or below the dentate line?
Think about the wiring. Visceral versus somatic.
If you aren't sure, rewind about 90 seconds. Trust me, it'll matter when we get to hemorrhoids later.
Absolutely.
All right, let's move to section 2, the detective work, the examination. Baily and Love has a quote here that is, well, it's blunt. If you don't put your finger in, you might put your foot in it.
It's a classic surgical aphorism. It means if you skip the digital rectal exam, the DRE, you're going to miss the diagnosis and embarrass yourself. You cannot diagnose anal pathology from a conversation across the desk.
But let's be real, it is an awkward exam for both parties. How does the text suggest we handle the cringe factor?
Professionalism and protocol. You need a private environment. You must have a chaperone, not just for the patient's comfort, but for your legal security.
Right.
And you need excellent lighting. You can't rely on the ceiling light. You need a focused lamp.
And position. You can't just have them hop on a table like a standard checkup.
Correct. The classic position is the left lateral, also known as Sims position. The patient lies on their left side, knees drawn up, but you might also use the knee-elbow position, or if you have a specialized chair, the lithotomy position. The text is clear. Use whatever position gives you the best view.
So we look, then we touch. What are we feeling for? Because lumps seems too vague.
Oh, it's so much more. You are doing a sweep of the entire pelvic floor. You are assessing the tone of the night watchman, that resting pressure. Does it feel tight, loose? You ask them to squeeze to check the emergency brake.
Testing the system.
You're feeling for induration hardness that suggests an abscess or cancer. Anteriorly in men, you check the prostate. In women, the cervix. You check the pouch of Douglas for tenderness. It is a comprehensive scan.
And then we use tools. Proctoscopy versus sigmoidoscopy. Is it just about length?
It's depth and intent. A proctoscope is short and wide. It is designed to visualize the anal canal itself, specifically to see hemorrhoids and the dentate line.
Okay.
A sigmoidoscope goes higher into the rectum and sigmoid colon. And the text is adamant about this. You must use the sigmoidoscope to rule out higher pathology.
Right, because treating someone's hemorrhoids while missing the rectal cancer 10 centimeters up is the ultimate foot-in-it moment.
Exactly. Never assume the bleeding is just from the obvious piles.
Oh, let's get into the pathology then. Section 3, the big 3, fissures, hemorrhoids, and itch. Let's start with fissures.
Let's imagine a fictional patient. Let's call him Paul. Paul is 28. He looks terrified. He says when he goes to the bathroom, it feels like he is passing glass.
The classic line.
There is bright red blood on the paper. And crucially, he tells you he is skipping meals because he is afraid to defecate.
Paul is the textbook case for an anal fissure, and specifically an acute fissure.
So what is actually happening to Paul? Is he just really sensitive?
No, he has a physical wound. A fissure is a longitudinal tear in the anoderm, that sensitive skin below the dentate line.
A pain line.
Remember we said that's where the pain lives. That's why Paul is in agony. And 90% of the time, this tear is in the posterior midline.
Why the back middle? Why not the sides?
It's a design flaw in human anatomy. The blood supply to the posterior midline is poorer than the rest of the canal. It's a watershed area for perfusion. Plus, the arrangement of the external sphincter fibers provides less support there. It splits easily.
So a tear happens, maybe from a heart stool, it hurts. What does the body do? It panics. The internal sphincter, the night watchman, goes into a spasm to protect the area. But this is where biology backfires. The spasm clamps down on the blood vessels that pass through the muscle to feed the skin.
So the spasm cuts off the blood supply.
Exactly. It causes ischemia. And without blood, the tear cannot heal.
And because it doesn't heal,
It keeps hurting. Because it hurts, the muscle spasms more.
it's a vicious cycle. Pain leads to spasm leads to ischemia prevents healing, leading to more pain.
Correct. So to treat Paul, we have to break the cycle. And the easiest link to break is the spasm. The strategy is simple. Relax the muscle.
How? Did we tell him to meditate?
We start with the basics. Fiber and fluids to soften the stool so we stop re-tearing it. Warm baths to encourage relaxation. But medically, we use chemical sphincterotomy. We apply ointments like GTN, that's glycerol trinitrate, or diltiazem.
GTN, that's heart medication.
It is. It's a nitric oxide donor. It forces the smooth muscle of the sphincter to relax. This restores blood flow and allows the fissure to heal.
But there's a catch.
The downside. Baily and Love warns about this. It dilates blood vessels in the head, too. It gives patients a pounding headache.
So you cure the pain in the bottom, get a pain in the head. What if the cream fails?
We can inject Botox into the sphincter to paralyze it temporarily. And if that fails, we do it surgically. Lateral internal sphincterotomy. We literally cut a small portion of the night watchman to permanently lower the pressure. It works 95% of the time.
But you're cutting the guard.
Yes. And the risk is minor incontinence. He might get a bit lazy with gas. But for a patient in Paul's level of pain, it's usually a trade they're willing to make.
Let's check in again. Why do we target the internal sphincter muscle when the problem is a tear in the skin?
It is not just about making the hole bigger. It is all about blood flow. If you missed the ischemia part of the cycle, listen to Paul's case again. It's the key to understanding the treatment.
Moving on to topic B, hemorrhoids. Or piles.
The plumbing problem.
Now, Baily and Love clarifies something important here. We all have anal cushions. They aren't tumors. They aren't invaders.
No, they are normal anatomy. Anal cushions are vascular, spongy pads located at 3, 7, and 11 o'clock. They act like the washers in a tap. They help the sphincters seal the canal completely airtight and watertight.
So when do they become hemorrhoids?
When the sliding mechanism fails. The theory is that the connective tissue anchoring these cushions weakens, usually from straining, constipation, or aging. The cushions slide down, become engorged with blood, and bleed.
You mentioned 3, 7, and 11 o'clock. Is that random?
No, it's anatomical. It follows the branches of the superior rectal artery. If you view the patient in the lithotomy position, legs up, the cushions are left lateral at 3, right posterior at 7, and right anterior at 11. That is the clock anchor for diagnosis.
And we classify them by how much they misbehave. Walk us through the degrees.
A ladder of prolapse.
First degree.
They bleed but stay inside. You only see them with the scope.
Second degree.
They pop out, they prolapse when you push,
Yeah.
but slide back in on their own. Spontaneous reduction.
Third degree.
They pop out, and you have to physically push them back in. Manual reduction.
And fourth degree must be.
They are out and they stay out. Irreducible.
Ouch. So treatment matches the degree.
Exactly. For first and second degree, we can band them. Rubber band ligation.
This is where the dentate line comes back, right?
Crucially. You must place the band strictly above the dentate line. If you grab skin below the line, you are clamping a thematic nerve. The patient will experience 10 out of 10 pain instantly.
Note to self. Stay above the line. What about the severe ones? The third and fourth degrees?
Surgery. The classic is the Milligan-Morgan hemorrhoidectomy, where we excise the cushions and leave the wounds open to heal. Or the Ferguson technique, where we stitch them closed.
What about staples? I've heard of that.
Right. There is the stapled hemorrhoidopexy, or PPH. It uses a circular stapler to remove a ring of tissue above the hemorrhoids and pull everything back up. It lifts the cushions back into place like pulling up sagging pants.
Less pain.
Less pain, yes, because the cutting happens in the visceral zone. But the text warns of higher recurrence rates and a specific risk called urgency, where the patient feels a constant need to go.
Brief touch on the third of the big three, pruritus ani, the itch.
This is a tragedy of good intentions.
The cleanliness trap.
Exactly. The patient feels itchy, they assume they are dirty, so they scrub. They use soap, wet wipes, sanitizers. This strips the natural protective oils, the lipid barrier, from the anal skin. The skin gets dry, cracks, and weeps fluid. The weeping causes inflammation, which causes
Don't itch, so they scrub harder.
and the cycle just destroys the skin barrier. The treatment is counterintuitive. Stop cleaning. Use water only. Pat dry. Don't rub. Keep it dry. And in kids, always check for threadworms.
Let's move to section 4, sexes and tunnels, abscesses and fistulas. This seems like a darker turn.
This is where anatomy meets infection. The origin story here is the cryptoglandular theory.
Sounds mysterious.
It's pretty mechanical. Deep inside the canal, right at the dentate line, there are these tiny pockets called crypts. At the bottom of these crypts are anal glands that tunnel into the space between the two sphincters, the intersphincteric space. If one of these glands gets blocked, it's like a blocked pore on your face. It gets infected, it fills with pus.
And pus under pressure needs a place to go?
Ubi pus, ibi evacua. Where there is pus, let it out. If it tracks down, it's a perianal abscess. If it tracks sideways through the external sphincter, it's an ischiorectal abscess.
The text is very aggressive about treatment here.
It has to be. The rule is, if it is indurated, so hard and tender, drain it. Do not wait for fluctuation, that soft, boggy feeling. If you wait for that, the infection has already eaten through significant muscle and fat.
So you're behind the curve.
You are letting the fire burn the house down while waiting for the fire truck.
Drain early. But often, draining isn't the end. It leaves a tunnel.
A fistula in ano. This is a chronic tract connecting the internal gland, the source, to the external skin where the abscess burst.
And these tunnels can go anywhere.
They follow patterns. And we have a famous navigation tool called Goodsall's rule.
This is a classic exam question. Explain Goodsall's rule.
Okay, so imagine a line drawn horizontally across the anus, splitting it into a front, or anterior, half and a back, posterior half.
Got it.
Goodsall's rule predicts the path of the tunnel based on the external opening. If the opening is anterior to the line, the track usually goes straight into the canal, short and direct, like the spoke of a wheel.
And if it's in the back?
If the opening is posterior to the line, the track usually curves around to enter at the posterior midline.
The horseshoe.
Exactly. It takes a curved path.
Let's test this. Let's create a patient, Maria. Maria had an abscess drained a few months ago. Now she has a weeping opening on her buttock about 3 centimeters from the anus in the posterior position.
Okay. Because it is posterior, we do not expect the tunnel to go straight in towards the anus. We expect it to curve around the back and enter at the 6 o'clock position, the posterior midline.
If the surgeon ignores the rule and probes straight in,
They will create a false passage. They'll punch a new hole through healthy muscle and turn a simple fistula into a complex nightmare.
once we map it, how do we fix it? Can we just cut it open?
Well, that depends on the muscles. This brings us to Park's classification. If the fistula is intersphincteric, so just between the muscles, we can often lay it open. We do a fistulotomy.
Okay.
But if the fistula is cransphincteric, if it cuts through a significant chunk of the emergency brake, the external sphincter, we can't just slice it.
Because you'd sever the muscle and cause incontinence?
Exactly. You'd cure the fistula but ruin the patient's life. In these cases, we use a seton.
A thread.
Yes. We pass a surgical thread through the tunnel and tie it in a loop. It keeps the track open, allowing it to drain and the inflammation to settle. It prevents a new abscess from forming.
So it's a drain.
Sometimes. Or we can tighten it slowly over weeks. This cuts through the muscle very gradually, millimeter by millimeter, allowing scar tissue to form behind the thread. It holds the muscle ends together as it cuts.
That's ingenious. A slow motion cut to preserve structural integrity.
It's a game of patience.
Quick check-in for the listener. If you see an external opening 2 centimeters posterior to the anal verge, where's the internal opening likely to be?
Remember the horseshoe. It curves to the posterior midline. Don't probe straight.
Section 5. The driver's seat. We're covering palatal sinus and incontinence. Why driver's seat?
Because palatal sinus was historically called Jeep bottom. It was an epidemic among Jeep drivers in WWII.
This happens in the natal cleft, the crack of the buttocks, way above the anus. We used to think this was congenital, right? That you were born with it.
We did, but Baily and Love is clear. This is an acquired condition. The theory involves 3 things: hair, friction, and suction.
How does that work?
Loose hairs accumulate in the cleft. The rolling movement of the buttocks while walking or driving creates a suction force, and the scales on a hair act like barbs on a fishhook. They only allow the hair to move one way.
So the hair drills itself into the skin?
It literally drills in. It causes a foreign body reaction, infection, and a sinus forms.
That changes the treatment entirely. It's not about fixing a birth defect. It's about changing the environment.
Correct. If you just cut it out and stitch it up in the midline, the deep cleft is still there. The friction is still there. The hair drills back in. Recurrence is high.
So what's the fix?
Modern surgery, like the Keradakis flap or Bascom's procedure, focuses on flattening the cleft and moving the scar off the midline.
Move the scar, stop the suction, stop the recurrence.
Exactly.
Finally, incontinence. The text calls this a devastating social condition.
It leads to total isolation. People are afraid to leave their homes. And the most common cause is obstetric trauma damage to the sphincter during childbirth that might not show up until decades later when the muscles naturally weaken with age.
How do we see the damage? We can't exactly X-ray a muscle.
We use endoluminal ultrasound. It gives you a cross-section view of the canal, like a donut. The internal sphincter is a black ring. The external is a mixed gray ring. We look for the gap in the donut.
And if we find a gap, can we fix a broken dam?
We have options. We start with conservative management biofeedback to retrain the remaining muscle, and loperamide to firm up the stool. Surgically, we can do an overlap repair, finding the scarred ends of the muscle and overlapping them to tighten the ring.
And what if that's not enough?
Well, the game changer for many is sacral nerve stimulation, SNS.
That sounds high-tech.
It's a pacemaker for the pelvis. We place a lead onto the S3 nerve root. It delivers a continuous low-voltage pulse that stimulates the sphincter and, crucially, modulates the sensation. It has revolutionized the management of fecal incontinence for patients where surgery failed or isn't an option.
Incredible. We've gone from the mechanics of a simple valve to nerve modulation.
The deep field.
Let's wrap this up. We've covered a lot of ground. Let's give the listener the anchors, the things they must not forget.
Right.
1, the sphincters.
The internal is the night watchman, autonomic, always on. Right. The external is the emergency brake, voluntary short bursts.
2, the dentate line.
This is the pain line. Above is dull, below is sharp. Know where you are.
3, hemorrhoids.
They are sliding cushions at 3, 7, and 11 o'clock. And remember, band above the line.
And 4, Goodsall's rule.
Anterior openings go straight. Posterior openings curve to the midline.
And a final thought for the road.
You know, reviewing this chapter, I'm struck by the mismatch. So many of these pathologies, fissures, hemorrhoids, pulmonal sinus, are diseases of modern lifestyle. We sit too much. We eat processed food that makes stool hard. We strain on toilets that are designed for sitting rather than squatting. Our ancient anatomy is struggling to adapt to our modern environment. The security system is robust, but we are testing its limits every single day.
That is provocative thought. Maybe the best surgical advice is to eat an apple, drink water, and go for a walk.
It usually is.
Well, that brings us to the end of this deep dive. As always, this was an interpretation of Baily and Love.
Please go open the book, look at the diagrams, verify the anatomy, use this conversation to make the reading easier, but do the reading.
Thanks for listening. Until next time, keep asking the hard questions.